So here's the data that's just starting to come out with that. We surveyed an internet survey of 2,243 respondents who completed this survey. We asked questions like, imagine there's a new test for Alzheimer's. You had to pay for it yourself, not covered by insurance. It's going to predict whether you have it in the future. And we varied lots, we randomized people in lots of ways. It was a kind of clever, we think, sophisticated design. You think about it. Would you want to know the test would predict if you had Alzheimer's? And we tell you the chance that you will get it by age 70 is 10% or 25%. And we varied whether we told you it was a perfect test or imperfect test. And in fact, most people told us they would want that test. And we have a lot of data on how it varies by their age and income and education and lots of other things. And then we asked them, how much would you pay for that test? And they told us, there's a big range. But, a couple of $100 they would pay for that test. Again, suggesting that, as we hypothesized, people value information from diagnostics. And we told them, imagine there's nothing you can do about this. By the time we told you had the, prediction of the future test. We did it with arthritis. People, same, wanted to know. Actually, more wanted to know. Some people didn't want to know if they had Alzheimer's, which, maybe is not surprising. You have to live with that burden. We asked about breast cancer. People seem to want to know and are willing to pay a lot for that information. Only the women got the breast cancer, only the men got the prostate cancer. And, same kind of result, if anything, even more. So we'll have a lot more to say about this in the future. We're analyzing the data and writing it up. The other component of this in-health-supported project is to really scrutinize those cost-effectiveness analyses that are devoted to in vitro diagnostics and really look at how they measured outcomes, whether they took any account into this kind of preference. We also, by the way, told them about risks of tests. I don't have it on the slide, so we do want to know about their views on potential harms and how they process probabilistic information. Okay, so let me just conclude then on a few thoughts. This is a recent paper. I'm part of this international working group on health technology assessment advancement, we call it, and some of these authors you might know and recognize. So this is really this phenomenon of health technology assessment and institutions devoted to sifting through evidence and doing evidence syntheses. They don't call it comparative effectiveness in other countries. Typically, they call it health technology assessment. Sometimes they call it relative effectiveness. We looked at whether they adhere to what we call good principles for doing this kind of research. Are they transparent? Do they have opportunities for stakeholder input? Do they take a societal perspective? Do they monitor the impacts of results? On and on and on. We found, you can read the paper, tremendous variation around the world. And I think part of what we need in the future is not only better evidence, but better processes for reviewing that evidence. And, again, you can read more about it. So what do I think the implications are for the diagnostic and device companies and others who might be in this audience? I do think the evidence landscape has changed so that the rules of the game have changed a bit. And just like the FDA and safety and efficacy that came out of the 1962 amendments to the Food and Drug Cosmetic Act changed the rules of the game, comparative effectiveness that come out of MMA, ARRA, and now health reform really changed the rules of the game a bit. You have to start early. You've got to build some of these considerations into the development program. You've got to get the comparator right, either in the clinical trial, typically, and in the other kinds of evidence you do. You certainly need to bring outcomes data to the payers. You need to support the value story. I think you need to anticipate the comparative effectiveness review. And, if you don't produce it, others are going to. Increasingly, the health technology agencies are going to do it themselves. To some extent, this has been true for a while, but I think it's just re-emphasized and ever more important in the new climate, and I don't think it's sort of optional anymore, which to some extent it used to be. So my last slide, I think, and I'll just sort of repeat some of the thoughts I mentioned already. I think comparative effectiveness research's impact has been limited to date, but will be greater with changes in incentives that, I think will come through payment reform, bundling in particular, and delivery reform. The evidence will always be messy for reasons we've talked about, but I think when you have the information and you've changed the incentives, there's a much greater probability that the information will be used. I think we'll continue to see the number of cost-effectiveness analyses increase. I think we'll always have a very difficult relationship with this kind of information in the U.S. and elsewhere, as we've seen, but particularly in the U.S. I think the resistance will continue. And I think this information, comparative effectiveness and cost effectiveness, will play a more important role in the future. Thomas mentioned a commercial, so I'll do my quick one. We have a course, if anybody's interested on the methods of this, at the Museum of Science, at Tufts Medical Center is offering this in June. Thank you very much.